Coming up on Leaders in Healthcare, Dr. Alexander Vuckovic is a Massachusetts-based psychiatrist, psychopharmacologist, and assistant professor at Harvard Medical School. With over 35 years of clinical experience and an extensive list of research publications, he is an industry-leading expert in the area of nootropics and the development of natural treatments for mental illness. Join us to explore the cutting-edge science of depression treatment, learn about the history of psychotropic medications, and the evolution of therapies over the last century, including his thoughts on the latest developments in psychedelics. You won't want to miss this episode.
Have you heard of Timothy Leary? The use of LSD. There are probably 20 to 30 natural substances which appear to have some efficacy in the treatment of depression. When it comes to being able to do what our friends the cardiologists can do, which is, hey, let's do a test. We'll figure out what's wrong with you. We got nothing. The next big revolution was the SSRIs. The odds of that drug helping that episode of that condition, the first thing that you give them is about 30%. Of that group, about half are going to stop it because it makes them feel dead inside.
What is going on in mental health right now? This continually bubbles up in just the news and media, in people's personal experiences in their own lives. What is going on?
Well, here's the thing. We are, I think, often trapped in the present. I've been doing this for 40 years, and I often ask that question, when I was strapping young 25-year-old residents. It's like, what's happening here? Mental health is going crazy. What are you people doing to people who are suffering? It's been one thing after another, and there have been, a lot of goings on diagnostically in the field, which then kind of turned to nothing. There's been a lot of therapeutics, which often turn to nothing. And I think that the media in general are always looking for the next shiny object in terms of therapeutics. And also for the next shiny diagnostic object. So right now, there is presumably a mental health crisis. I don't know. I don't want to be a contrarian about this, but I'm just about as busy today as I was 10 years ago, 20 years ago, 30 years ago. I got the same number of people waiting outside the office. And yet, things have changed. And I think we have to acknowledge that. The main thing is that the pandemic, I think, brought home the environmental factors that are involved in mental illness. In particular, when you isolate people and when you get them scared about their futures, unsurprisingly, a much greater number of those people are going to feel very anxious and quite often very depressed. And that, in a nutshell, is, I think, where the last few years have been.
And so, is there greater rates of mental health disorders now? Is this becoming more prevalent? Is it something in the water? Pandemic definitely, in terms of isolation, started kicking things off in that manner. But if you're just as busy back then as you were today, what is the actual difference in mental health in the population then?
Well, I think that if you really look at it, as a rolling phenomenon, there are dips as well as blips in the incidence of certain disorders. Depression and anxiety are very nonspecific phenomena. They're not diseases per se. On kind of the end of the distribution of depression and anxiety are diseases. Melancholic depression, suicidal depression, psychotic depression. Or an anxiety disorder that is so severe that you want to kill yourself. Those are diseases, even though we still don't know where they come from precisely. The great majority of people suffering from that kind of mental discomfort are folks who might not feel that way next month. Or who might not feel that way next year. And if you think about it, we were really under chronic stress for 2 years or more, beginning in the spring of 2020, and we're only now sort of beginning to see the clouds clear from that phenomenon. And the other problem is that we are also in a position of doing bad things to our children when these things happen. So we got these poor kids who really suffer because their brains are not developed, and where all of a sudden you got a generation of kids who are literally behind by 1 to 2 years in terms of their life development. those kids may very well suffer going forward. Previous, quote, epidemics of things like, you may or may not recall, you don't recall because you're a kid, but there was an epidemic of anorexia and bulimia in the 1980s. Everybody had bulimia. And that faded away. Is there such a thing as bulimia? Of course. Has there always been? Yes, but there was a blip. Similarly, and again, maybe a little more, politically fraught, is transgender symptomatology, and the question of, my God, why are we seeing suddenly, 10 times as many kids in particular who are complaining of gender dysphoria? And I think that again speaks to the environmental elements of this and of things like social contagion and things that we really need to be careful about. So you may also remember there was, I think, for a time, a phenomenon of the satanic worship in daycare centers.
That might have been a little before my time as well.
Yes, children were supposedly being tortured by the satanic worshippers who ran daycare centers. People went to jail for like decades for this craziness, in retrospect.
Holy.
So I'm just putting in perspective that what we're seeing today is not that wildly out of the ordinary when it comes to the blips of the epidemiology of mental disorders. The core symptoms, the core illnesses, your depressions, your anxiety, the severe depression, severe anxiety, bipolar disorder, schizophrenia, those are forever disorders. They have always been here, they will continue to be here, and they run across all cultural and geographic barriers. They are a function of the human condition. And again, what's really tremendously frustrating is that we have no idea where any of that really comes from. We posit multifactorial causes. Obviously, genetics is a part of it, the environmental stresses, trauma, all of that stuff. And yet, when it comes to being able to do what our friends, the cardiologists, can do, which is, hey, let's do a test. We'll figure out what's wrong with you. We got nothing. What we have is a very old.
You mean the PHQ-9 isn't 100% perfect? Are you serious? Oh my goodness.
Are your viewers going to be asking us about the PHQ-9? I hope not. No, of course, it's we're measuring phenomena. We are not figuring out etiologies, and which brings me then to the real problem, which is that all of our treatments at the end of the day are empirical. We try things that we think might work, or sometimes we try things for no particular reason, and they turn out to work. Lithium was invented by a crazy psychiatrist in Australia who noticed that when he injected lithium into rats, and he did so because he thought that rats could be made depressed by sodium urate, uric acid. So he injected rats with sodium urate and lithium urate, and the lithium rats slowed down. And from this, he figured, well, of course, this is going to treat bipolar disorder. What? Who thinks like this? And yet he discovered probably the most revolutionary pharmacologic treatment in the history of psychiatry.
Attracting top healthcare talent is crucial for providing exceptional patient care, but connecting with the right professionals can be time-consuming and complex. Cherry Health bridges the gap. Our network allows you to showcase your organization, post jobs with precision and ease, and directly engage with healthcare providers actively searching for roles like yours. Whether you're an ambitious do-it-yourselfer or a seasoned recruiter, our intuitive web platform makes it easy to showcase your open roles and organize your applicants. Need a more personalized approach? Cherry Health Staffing Solutions offers dedicated recruiters to find and vet the perfect candidates for your specific needs. Build your dream team with Cherry Health. Visit www.cherry.health and start growing your team today.
That is quite the backstory there. I heard there was another side of it too. There was like some mining town somewhere that had just lithium, high levels of it in the water, and everybody was like pretty chilled out. And then they started thinking maybe you could do something there too.
There are lithium baths and things of that sort. How much lithium do you absorb from those? Try zero. So that too was an interesting phenomenon, but probably, if not apocryphal, than just not so.
It's interesting, though, you mentioned sort of like it is very empirical. What are your thoughts on off-label treatments in general? Like, I know this comes up a fair bit in clinical practice. It's like, okay, well, I have a theory here. It's not founded in, the literature at this point, but maybe going for an ADHD medication when it seems like more of a depressive symptom. Like, how often do you wind up kind of picking and choosing your different potions that don't necessarily match the indications?
Well, when it comes to what's available to play with, we're talking about pharma products, which are generally Me Too offshoots of one particular insight that occurred, or just again one accidental insight. So when we saw lithium, it was very unique because there's no way you can do a Me Too for lithium. Having said that, because it worked in bipolar disorder, people decided let's try it in unipolar depressive disorder, and it appears to have some efficacy, certainly in prevention of unipolar depression. It has efficacy when you add it to an antidepressant, even if someone is not bipolar. So those kind of experiments go on all the time, and they definitely occur, in the clinic, so to speak, as well as, within academic centers. But after lithium, you had antipsychotics, which again came up in the early 1950s, by the way. Think of this time frame. I mean, any other branch of medicine, you wait 10 years and the world has turned upside down in terms of what you have to offer patients. We're still using stuff from like 80 years ago. You had antipsychotics from the 50s, a bunch of Me Too antipsychotics. Finally, you got atypical antipsychotics, which didn't cause people to look like circus freaks. Clozapine, that was 1971. So 20 years after the original antipsychotics, you had clozapine. Within 5 to 10 years after the antipsychotics, you had your first antidepressants, accidentally, MAO inhibitors, which were given to tuberculous patients, and which turned out to make some of them giddy. And that all of a sudden became an antidepressant. The tricyclic drugs, which then came out in the 60s, sort of Me Too drugs based on the mechanism of the MAO inhibitors to try to, inhibit the metabolism of the norepinephrine and serotonin. The next big revolution was the SSRIs. When I was training, the first one, came about in the late 1980s, and we're still there. We're 40 years later. We're still doing SSRIs, which, by the way, are not as strong and effective as tricyclics and MAO inhibitors from 60 and 80 years ago.
A little more palatable often, though.
Well, there's a little more, although, they have their own side effects. And, a lot of if you really look at the numbers, as it were, if you take a depressed patient who's never been depressed before and who comes to your office and says, look, I can't stand the way I feel. I've tried therapy for a few weeks. It's not doing any good. I can't function at work. I'm getting really negative, horrible thoughts about wanting to die. Help me out. Okay, you give that person an SSRI, and the odds of that drug helping that episode of that condition, the first thing that you give them is about 30%. Maybe you'll get 50% who actually say they feel better, but of that group, about half are going to stop it because it makes them feel dead inside, kind of emotionally not there. It causes sexual dysfunction, including inability to orgasm, sometimes actual erectile dysfunction in men. And by the time you're done with that list of things, you're down to that core group of 30%. Then you give them a second drug, and you pick up another 20%. But by the time you're done, let's say after a year of treatment, you have successfully treated about 80% of people with the depressive episode. And yet, when you say successfully, of those 80%, maybe half, 40%, are really in what we would call a good remission from their illness and will go on to lead pretty reasonable lives. The other 40% are in a kind of a semi-remission where they're at risk for further episodes, where they have to stay on these drugs for extended periods of time, and where the patients aren't that happy about it. That's where we are today.
What are your thoughts on sort of this newer generation? I guess it's not even a newer generation of medications. This is stuff that's been around forever, but the psychedelics are now becoming a lot more popular, like treatment resistant depression, going for your ketamine infusion every 3 weeks. Why not throw some mushrooms at it, see what happens? What are your thoughts on this sort of new and evolving facet of psychiatric care?
Have you heard of Timothy Leary?
No.
He was a Harvard professor in the 1960s. Guess what he invented, more or less?
What's that?
LSD, the use of LSD as a way of opening up your mind, of setting aside the cares of the world, of finding a new reality. So these drugs go back many, many years. They're all obviously nominally illegal, but people know how to get them and how to make them. The ketamine thing was, I think, it's good that ketamine came out first for a simple reason, which is that it does seem to work, even though it is nominally a hallucinogen, at least at higher dosages. You can get hallucinations with it. It is generally well tolerated, and there's no question that it is a rapid sort of treatment for acute suicidal depression. So much so that, there have been studies that indicate that in emergency room settings, where somebody comes in suicidal and you think, oh my God, I got to send this person to the hospital, you can give them an injection of ketamine and the suicidality can fade away within hours. So that's impressive. Now, as with all things, there are caveats. And the main one is you don't really know the impact in the long term on the natural history of the disorder, as well as on any potential cognitive problems that may arise when a brain is exposed to that kind of stuff on a regular basis. And that's a problem. When you get into what's happening today, which is psilocybin, MDMA, and LSD, being offered, in microdoses or bigger doses to people with PTSD, post-traumatic stress disorder, or major depressive disorder. It's the Wild West. The research, frankly, has not been very powerful in terms of its efficacy. People who take this stuff know they're taking something powerful. It's almost impossible to do a double-blind study of hallucinogens.
Yeah, that would not be a subtle effect.
Yeah, so you got to take it with a grain of salt, unfortunately. Again, I go back to the 1960s study, which seemed to indicate that if you took acutely psychotic patients into a hospital setting and you ran their blood through a dialysis machine, their psychosis appeared to fade away to nothing. And so the hypothesis was, of course, we are removing the thing that causes psychosis from the bloodstream when we do dialysis. And then somebody had the clever idea, well, why don't we just pretend to do dialysis in these patients and run their blood through something which is not a dialysis machine? And unsurprisingly, they all got better too. So the power of that kind of suggestion in this field is remarkable, and it humbles you when you try to figure out, well, my brilliant new idea that I've been giving to all my new patients, they're all getting better. That's just not necessarily true. And I'm not, I'm not saying that that nothing will come of this. I think it's worth studying longer, but it's certainly not ready for clinical prime time.
So cautious optimism. We need more data here. Maybe there's some signal amongst the noise, but yeah, when you look at it from the traditional research approach, it'd be very, very difficult to double blind a ketamine infusion trial. And then what are you actually comparing to?
Well, it's interesting compared to, that problem is there with regular antidepressants too, because, smart patients can figure it out if they're taking a sugar pill versus something that's causing some kind of side effect. But certain techniques, you take a look at some of these non-pharmacologic techniques, say bright light therapy. You can expose someone to a very bright light, which is not enough to treat their depression, but they think they're exposed to a bright light. You can then, do the double-blind study and expose the other cohort of patients to an incredibly bright light of 10,000 lumens, and they'll also call that a bright light. And those studies have been done, and they clearly show the superior efficacy of real bright light therapy to even sham bright light therapy, as we would call it. So that can happen. And that's why I'm a fan of bright lights. I'm also a fan of bright lights because it is the most non toxic, albeit somewhat labor intensive, treatment in psychiatry, and certainly the psychiatry of depression. I mean, my patients get sick and tired of hearing me talk about bright lights. But this is the direction I think that we want to go, to try to really tease out what works, as well as to be very, humble about the next bright object. And similarly, the same thing happened with the transcranial magnetic stimulation treatment, where you can do a sham TMS fairly believably, where a person can feel something tickling his brain, but it's not the full impact of a full magnetic field. And again, there's been demonstrated efficacy in that kind of a setting for TMS. So here again, I am a fan of transcranial magnetic stimulation as well, especially, I don't know, I'm sure you're aware of these new intensive TMS treatments where you do 10 treatments a day for 5 days.
Holy smokes. Okay, that's quite the protocol. No, I've never heard of this previously.
Well, it's been around for about 2 or 3 years, well, maybe even 3 or 4 years. The original transcranial magnetic treatments came out, I don't know, 15, 20 years ago, so they've been around for quite a while. Their results are okay, but not astounding. I mean, those double-blind studies, maybe you get 30+% of people better versus 10% on the sham. So it's real. There's something happening there, but it's not magic. If you blast people with the magnets 10 times a day for 5 days, you get an 80+% response rate, which is impressive. Does it last? More unanswered questions. For some people, probably. For other people, it fades away. But we do now have a new technology that we can at least say is somewhat scientifically based. It just goes back to trying to be empirical with this, because we don't know how or why these things work. And I haven't even discussed, the most kind of traditionally effective psychiatric treatment that's more than 100 years old, which is electroconvulsive therapy, electroshock therapy that everybody's frightened to death of. Well, it's also a lifesaver, just as ketamine is, because it will make suicidal people non-suicidal relatively rapidly. And yes, there are costs involved in terms of memory in particular, and the potential effects of anesthesia, pain, things of that sort. But that too is in our armamentarium and has been forever. So we almost forget about it when we discuss what's new on the horizon.
Yeah, I can confirm. I did remember doing a couple days of ECT therapy on patients at the inpatient wing in the Royal Alex Hospital in Edmonton back in medical school. And it worked. People would come in for it quite religiously.
Oh yeah, no, and then it's again, when it comes to, remember that kind of that end of the distribution of illness, the people with really big time stuff, but nothing else helps. We have treatments that do help, and yes, they have costs, but it's a little bit like the chemotherapy of cancer. Severe depression, severe psychosis are deadly disorders. They have mortality rates of 10 to 20%, and it's not 50 to 80%, thank God, but that's close enough that I think you have to acknowledge that you just have to sometimes take what you get in terms of side effects.
Are you a healthcare professional ready to take the next step in your career? Do you dream of a role where you truly make a difference in a community that's perfect for you and your family? Well then, let me introduce you to Cherry Health. Our platform puts thousands of healthcare opportunities right at your fingertips. Explore jobs by location, specialty, compensation, and more. All on an intuitive map-based platform, available on Android, iOS, or your computer's internet browser. Create your professional profile for free and get started messaging directly with employers. Beyond the app, Cherry Health also offers personalized, white-glove recruiting services who can guide you every step of the way. Your dream healthcare career is just a click or a phone call away. Visit www.cherry.health to start the next phase of your journey.
The mild, I guess, the moderate depression being a lot more common. What do you tend to lean towards nowadays in terms of more of the holistic stuff? I definitely want to cover the medical food side of things because I find that absolutely fascinating. And I mean, just in general, approaching this one, it's usually, okay, pharmacology, what kind of meds should we offer the patient, lifestyle management, like, are you still isolated after COVID, or do you need to go to the gym, do you need a boyfriend, etc. And then we've got the counseling and the psychotherapy and the talk therapy. Like, how do you actually approach a patient who's in that much more common, mild, moderate side of things with the, okay, let's start doing some of the stuff that doesn't have as many side effects, when these pieces often have, again, paucity in the research, probably just due to lack of commercialization interest around a lot of them.
That's part of it. In fact, if you look at the literature, there are probably 20 to 30 natural substances which appear to have some efficacy in the treatment of depression. And so it's all out there. There's a wide-ranging literature. A review that came out several years ago indicated that if you really do a sort of a critical study of the literature, there are only 4 nutritional items that appear to have demonstrable efficacy in the treatment of depression. And so I'm sorry, I'm veering into medical food too early, maybe, but
let's go there.
That's what's out there, and those 4 substances are the amino acid known as S-adenosylmethionine, the form of folic acid known as methylfolate, which again has a reason for being, and fish oil. In particular, fish oil containing a lot of the EPA omega-3 as opposed to the DHA. Weirdly enough, DHA is very important for growing babies and pregnant mothers, as well as for old folks to try to maintain their cognitive status, whereas in the middle of life, EPA is the relevant omega-3 for reasons that we're not sure about. The 4th item is vitamin D. And here again, this is a really unrecognized thing to some extent because it's so trivial and it's already out there. So people can't make a lot of money on it. But if your vitamin D level is low, you have a 4 times chance of becoming depressed compared to someone with a normal vitamin D. Same is true of vitamin B12, pretty much a similar story. And so those things are out there, and they're low-hanging fruit. I mean, for a clinician, I do blood tests, obviously. I check the levels of vitamins. I check the thyroid function of the patient, basic chem screen, anemia, things of that sort. Once you're done with all of that, you really are left with this small basket of potentially useful things, which, key term, is not harmful. We do not do harm with this basket. And so, I've really come around. I mean, I used to be, kind of a mad psychopharmacologist in my youth. I mean, we're all very enthusiastic, when we get started in this business. And I would just, get people on antidepressants. If they're not better, I'd add an antipsychotic to the antidepressant. If that's not better, I'd add some thyroid hormone. If that's not better, then they get ECT. That was my practice in the 1980s. Lately, and especially here again, this is where the humility grows. You watch patients that you get to know for more than just a few months. You watch people go through the life cycle of depression for 10, 20, 30 years, and you become very respectful of their life experience and what it is that they feel when it comes to getting treatment. And all of this kind of led me in the direction of trying to optimize these do no harm treatments, which clearly have efficacy in treating depression.
And how do you choose where to get started then? Like when it comes to, okay, we could do counseling, we could go for the supplementation route, we could go, you know what I mean? Like patients are going to say, okay, well, I've only got so much time, so much money. How do you start whittling that down to what's going to work the best?
Well, it's a good question. And when it comes to clinical practice, I want to be also very clear. I am not suggesting that you start by giving people nutraceuticals as primary treatments for the disease of depression. If I were suggesting that, then I could take my product off the market and skulk away to some desert island because the FDA wouldn't let me live in this country. However, if you begin treatment, as most doctors do, with an SSRI antidepressant for someone who's mildly to moderately depressed, again, if that person either is in therapy or, as often is the case, doesn't want to do therapy because they just want to get better and they don't want to talk to anybody. That's
All
not
too common.
unusual scenario. In those cases, you start them in the SSRI, and rather than jumping onto some other drug, if the SSRI is inadequate to their needs or if they have too many side effects at a therapeutic dosage, my next step is to add the nutraceuticals. And I used to tell people, okay, go to Amazon and purchase S-adenosylmethionine. Make sure it's a good, reputable seller. Make sure that it's a 400 milligram tablet. Make sure you take 4 of the 400 milligram tablets daily for maximum response. Then, when you've done that, go buy some fish oil, but it has to be triple strength fish oil. It contains a lot of EPA. Or the third thing, please go get a medical food, which was already available as a medical food at the time, which is L-methylfolate or Deplin. And then you can take all these 3 things together in a giant bowl while you're taking your antidepressant and dealing with depression. Many people have the self-discipline to do this. Many people do not. And so it was a limited sort of a phenomenon for me because it takes time to kind of figure out who is going to be able to do this and who's not. So the next thing I did was, well, you know what? Let's see if we can put these things together in one product, make it easy to take, and then the next step is once the antidepressant isn't working well enough, you add the new product. And it's a single thing. Mind you, I wish I could make it 1 capsule per day, but because of the volume involved in the fish oil, it's 2 capsules twice a day for the ideal dosages of all 3 items. But it's out there, and I'm marketing it as we speak.
Well, I think like the form factor and just making that roadblock or the hurdle that patients have to jump through in order to get to the treatment plan and like making it as smooth and frictionless as possible is super important. Like, I don't know, I have so many patients that just struggle with even the simplest of things, right? Like, okay, you got to do 5 push-ups a day and then we'll talk again next week. Did you do it? No, I was going to do it. I didn't get around to it. And then we talk about like, okay, we got to go get a whole bunch of like chemistry lab sounding ingredients sourced off the internet and start putting together our nutraceutical supplementation plan. Patients are like, oh my goodness, it's probably pretty anxiety inducing versus if you have something that's just like off the shelf, easy, ready to go, that probably takes a big part of that roadblock out of there.
So far, we found that to be the case. And I've started off with the folks who are already in my practice. And a lot of times, there are people who already are taking these 3 things. And we just replace it with this product. By the way, the product's name is Hedonia, in case you were wondering. And we just replace it with this product. By the way, the product's name is Hedonia, in case you were wondering.
Where did that name come from?
Well, it's a Greek root. And hedonia is, of course, the experience of pleasure. You're familiar with the term hedonism, which comes from that. And
everybody's favorite anhedonia, which is their common side of their depression, I guess.
There you go. So I figure you take the an off and you get hedonia. So that's why it's called what it's called. But it's really a lot easier to present this to a patient after they've had their first try at the SSRI. And I found that even in people who've been on these 3 things before together, really feel better on the Hedonia because we know exactly how much they're getting. We know exactly where it's coming from. It's not like 5 separate brands of SAMI, some of which may oxidize rapidly, which we've unfortunately seen. And it's so far so good.
What can you tell us in terms of like the power of the effect when it comes to like the evidence and just in your personal like experience over the years? How does it stack up compared to SSRI number 2 or 3 or throwing a little bit of trazodone in the mix?
Yep. So here's the thing. This goes back a ways. I did research on S-adenosylmethionine when I was in medical school. And it was part of, again, a hypothesis that an Italian group had supposed. They noticed that levels of S-adenosylmethionine, which naturally occurs in your bloodstream, were lower in patients with major psychiatric illnesses, psychoses. And in those cases, supposedly, you're draining this ubiquitous methyl donor. I'm going to get just a little wonky on you here. SAMe is the body's ubiquitous methyl donor, and it donates methyl groups to neurotransmitters. If you add a methyl group to serotonin, you get mescaline, which happens to be a hallucinogen. So the theory was, aha, we figured out schizophrenia. These people are using up all of their SAMe. They're making brain mescaline, and that's why they're hallucinating. It's brilliant if it's true. You'll notice there have been no Nobel Prizes being given for this yet. That's because when we tried to duplicate those studies, they were irreproducible, like many, many such studies. And so, as it turned out, my one claim to fame from a research point of view was that we did discover that men have higher ambient levels of SAMe than women. And that's actually true in rats as well as humans. So here again, that seems to be a mammal-wide phenomenon. And as you're probably aware, rats actually can get depressed. So we therefore, realized, well, maybe there's something to this. The incidence of depression in women is about 3 times that of the incidence of depression in men. And they're out there wandering around with low levels of SAMe. So the next thing you do is you give SAMe to people, and hey, it works. There were very, very strong studies in the European literature which compared SAMe, which at the time was actually given intravenously and intramuscularly, to clomipramine, which is, I'm sure you're aware, is an incredibly powerful tricyclic antidepressant. The best of the best, so to speak. And SAMe was equivalent in efficacy to clomipramine. Now, later on, studies of the oral preparation, which probably isn't absorbed as efficiently, which is one of the things we need to think about when we make a product like this, and so the more recent studies have not been as powerfully effective. But a number of studies have indicated that in this population that we're talking about, people who are on an SSRI who aren't getting better, you give SAMe to that population, and 50% of them get better. So
that's
that was
wild.
That was
how much better is better.
Well, most times when you get that, you're dealing with a statistical phenomenon, and as I'm sure if your depression score goes down by 3 points, then you've demonstrated clinical efficacy, even though that may make you only a little less depressed. In these kind of cases, it's the usual 50-50. About half the responders are robust responders. They really feel good. The other half feel kind of better, but it's like, no great shakes. So that's the case with SAMe. Second item, L-methylfolate. And this was something which, I had nothing to do with, but I was following with great interest over the 90s and the early 2000s. And you can do the same thing with methylfolate. You add 15 milligrams of methylfolate to a failed SSRI trial, and you get a 50% response rate on top of what you would have expected. And the theory on that one is fascinating because 70% of people with depression have a genetic defect called the MTHFR polymorphism. And that particular defect prevents them from converting dietary folate to brain permeable methylfolate. And so that group of patients are probably the main beneficiaries of giving people exogenous methylfolate, which goes directly, L-methylfolate, which goes directly into the brain. And interestingly, even in people without the polymorphism, people with what we call high inflammation depression, people who are obese, have elevated levels of sedrate, C-reactive protein, and such things, those people are also responders to methylfolate for reasons that are not entirely clear to us, except that it probably has some, anti-inflammatory qualities. So that's number 2 of our 4 items. Number 3 is fish oil. And here again, a colleague of mine at McLean Hospital, Andy Stoll, did a lot of studies indicating the efficacy of adjunctive fish oil to people with bipolar disorder. And he used massive amounts of fish oil, 6 grams a day. And it turns out that, yes, there is a beneficial effect of fish oil when you add it to mood stabilizers. Subsequent studies by my colleagues at Mass General, who also did the methylfolate studies and the early SAMI studies, also indicated that you could add, in particular, EPA-rich fish oil to people on SSRIs. Surprise, surprise, 40 to 50% of them get better. So we got 3 items, each of which, is contributing a little extra oomph to this group, which is mildly treatment resistant to start with. And that's the 3 that are together. Nobody's looked at the vitamin D piece, again, because the vitamin D is so ubiquitous. I just give it to my patients anyway. But that is how I got to the formulation. So we put out the first patent in 2000. We applied for the first patent in 2009. We got an ICHE patent in 2013, which would have allowed people to add vitamin D and compete with us. So we didn't like that. And we finally got a definitive patent in 2017 where nobody can add anything. If these 3 items are in it, then this is your intellectual property. And again, it's important because this is now something which we have, it's investor bait, so to speak, for people who are interested in trying to get behind something which could be a really important new technology. And the medical food piece, I think, is relevant because there really is a good argument that if you think about it, if SAMI levels are affected by ingesting SAMI, and if that is a nutritional deficit associated with depression, which it seems like it is, then SAMI is a medical food. Methylfolate, similarly, you've got the genetic deficit involved that you can't make up for by glomming giant mounds of folic acid containing vegetables. You got it. Fish oil is a little trickier. I think it's a legitimate medical food because if you were to ingest 1.5 grams of EPA in particular per day, you need to have a slab of salmon every single day of your life. That's enough to, after a while, just drive you running from the dining room. So that's the rationale for the medical food designation.
Now, are these foods naturally found in the types of diets where when we're talking about nutritional control, like I was just listening to a podcast from the CMAJ and they were talking about a study which was showing in terms of, SSRI versus following the Mediterranean diet, there was the equal effect in this particular study. Like, are these sorts of like the SAMe and the methylfolate and the vitamin D, like, is this all what's found in those types of foods in the Mediterranean diet?
Not in the amounts that are commensurate to what we're giving people. I think there's something positive to be said about the Mediterranean diet. Certainly the prevalence of the omega-3s is a big deal. If you include even the non-animal forms of omega-3s, your olive oils and things of that sort. SAMe itself is really not particularly prevalent in food items. And the methylfolate is not, even though folic acid is in a lot of things, including that diet. But if you think about it, if you're one of the 70% who can't metabolize oral folate to get into your brain, you can eat as much of that stuff as you want. It's not going to do you a lot of good.
It just go right through you. It's not bioavailable.
Right. But yeah, I'm sure that, this study is interesting, and as all such studies go, we want to reproduce if we can. Also, let's not forget, it's a bit labor intensive. The newest nutritional thing, of course, is the ketogenic diet, where there really seems to be something to be said for it as at least an adjunctive tool in the management of treatment-resistant conditions, including bipolar disorder, even schizophrenia. So I think the jury is still somewhat out on that, but it's intriguing. The real problem is when it comes to the more severe disorders, the discipline involved in being on a ketogenic diet is tremendous. And, just getting someone to do it who is already distracted, whether it be by severe anxiety and depression or by the voices in their head, is a project.
Yeah, no, even just anybody who's out there and of clear and sound mind, keto is a tall order.
It is. Well, this all goes back, there's nothing new in this world. This all goes back to Dr. Atkins in the 1980s. And, he's the one who pioneered this, and people were like laughing at him. And in reality, as a weight management tool, it's astonishingly effective until you start eating carbs again. So,
Which is hard to avoid.
right, exactly.
Yeah, my
It's
doctor
all,
told me I have to pick the cheese and the pepperoni off the pizza and just eat that. That'll cure me. That's the secret.
but yeah, it's kind of it is an exciting time in the field in that regard because we are looking, at everything that constitutes your environment. I mean, the stuff we're talking about today, light, food, I mean, it's there for the taking.
Well, this is the kind of stuff that people want to know more about, right? They want to look for these more natural alternatives and things that seem, I don't know, less like there's a ulterior motive or an incentive by a profit-seeking company to push on people.
Yeah, the problem is that most revolutionary medical advances have been made by profit-seeking companies who also want to do good things. So I agree with you. The pendulum swings, and right now it's definitely swinging in this particular direction. But I have great respect for companies which have made very effective treatments over the years. It's just that again, in this field of psychiatry, the fact that we're talking about treatments that were invented, almost a century ago, or in the case of ECT, in fact, a century ago, is a bit off-putting for those of us who want to make a difference, in the lives of patients.
It definitely seems a little bit like things are just not progressing fast enough. But I feel like if we asked the cardiologists, they'd probably say the same, despite having all their fancy PCK9 inhibitors and things now.
Well, they might say the same, but they of course would be wrong because there's also a ton more money in that, and a ton more research money in looking at these disorders. And here again, it's a matter of how much noise people make. In the AIDS epidemic, it was the AIDS sufferers who really drove policy, and they helped create the treatment for that horrendous illness. So that makes a big difference. Who's pushing? In psychiatry, I think people who suffer from these disorders are diffident by the nature of their illnesses, and also, frankly, by the stigma involved. Especially
Culturally, we've come a long way there. That seems to be like perhaps the biggest, not innovation, that's the wrong word for it, but advancement as a society.
well, but not really until recently. And when it comes to the athletes who have clearly suffered from things like depression and anxiety, and who've kind of come clean with it, I agree with you. It has made it be less of a stigma, but it's not a zero stigma. And there's a bunch of CEOs out there who are taking their lithium, and nobody knows about it.
Well, Dr. Vuckovic, you working on anything else cool these days?
Well, this is not enough. My main source of my professional life is my clinical practice. I have a very large psychopharm practice. I've developed it over the years. I also run a program at McLean Hospital, which is a 2-week evaluation program for people with difficult to treat disorders. So, I've seen sort of both sides of this thing, and it's been exciting, certainly, going forward. But I'm really excited about this stuff that I'm selling, the Hedonia. I think that it's going to make a big difference, and we're very much looking forward to helping people feel better.
Well, I'm definitely going to have to start taking a look at the nutraceutical side of things because this is like one of the blind spots in my practice. It's either SSRIs or go to the gym or talk to your therapist. It's usually sort of missing out on this whole facet. But it's fascinating to hear sort of the experience and the evidence and the anecdotes that people are having a lot of success in this department.
I believe so, and I want to certainly get the message out.
Very cool. Well, thank you so much for joining us today. Really appreciate you taking the time to share some of your wisdom.
Glad to.
What was the website again?
The website is, I got to get better at that. Sorry. The website, I got to say that before I thank you. It's hedonia.com, Hedonia.com. And it'll pop right up. Google's been good to us.
Awesome. Thank you so much.
You're very welcome.